Thank you for joining us for our second episode of the Salivary Gland Research Podcast. Last session, we were able to interview Dr. Bruce Baum, who made strides in the salivary gland field long before I was born. And today we have Dr. Randall Kimple, who is making strides in work with patients that have received radiation treatment for head and neck cancers, being interviewed by Kennedi, Weston, and Dr. Rob Copps. So can you introduce yourself, starting with Dr. Copps?
Yes, my name is Rob Koppers and I'm a biologist, but I'm working at the radiotherapy department in Groningen, where we have a lot of head and neck patients that are treated with radiation. So I started as a biologist and did my PhD in molecular pharmacology. So that made me feel like doing something about this terrible disease that we will hear more about, I think, in this podcast. In a pharmacology-based way, but that moved me from the pharmacology because I noticed that to repair these kind of organs that are damaged by radiation, you really the stem cells are the ones that are hit by the radiation and cannot repair your tissue anymore. So from there on, I focused on the stem cell research of the salivary gland, and we developed multiple ways of looking at this, and a lot of animal and in vitro research we did. And now the last years, or since 2 years now, we are running a clinical trial with a different type of stem cells that Randy is using for his study to cure the similar symptoms of the patient that have been irradiated for head and neck cancer.
Hello, my name is Kennedi Weston, and I am a fourth-year PhD student at University of Albany, the state of New York. And my current research is targeting senescent cells in aged salivary glands, particularly the salivary gland, and seeing the role of fisetin and antagonism in aging and topocyte-induced senescent cells in the salivary glands. My path, I originally majored in chemistry during my undergraduate studies, and my passion shifted when I started working with a project during my 2.5-year internship at FDA NCTR in Jefferson, Arkansas. And that kind of sparked my interest in more in biology, particularly in microbiology. And while I was applying for graduate programs, one of the contacts was University of Albany SUNY professor, and she let me join her lab during the summer, and that's when I started rotating. And Dr. Larson, she studies salivary glands, and she actually made me spark more interest in that, and also look into more of health disparities in when it comes to aging populations, since they're a vulnerable population. So I'm glad I'm able to integrate health disparities in my research for that too. So.
All right, great. And I'm Randy Kimple. I'm a professor at the University of Wisconsin in the state of in Madison, Wisconsin. I am a radiation oncologist and a physician scientist. So I did my undergraduate at Michigan State University studying environmental science, but then went to graduate school and medical school at the University of North Carolina, where I studied pharmacology in graduate school. And then completed a residency in radiation oncology, also at UNC, before moving to a postdoc here at Wisconsin, where my work really focused on viral oncology, so how viruses cause cancer. I sort of split my time about 1 day a week in the clinic taking care of patients with head and neck cancers, and the rest of the time running a research group. And over the past maybe 5 years or so, we've really developed an interest in salivary biology, the damage that radiation causes to the salivary glands. I've become quite familiar with some of the great work that Rob and his group has done over the years, and now are nearly complete with a phase 1 clinical trial, investigating a cell therapy for patients with radiation induced salivary dysfunction. So it's been really an exciting an exciting time and a real change in sort of the areas that we're focused on that, 10 years ago, I never would have predicted that I'd be working in this part of the field.
What are some unique interactions that you see working with the patients? And also, another question too, along with that connection, have you seen any health disparities too while working with your patients?
Yeah, so the things that I think really drove us to focus on this work and to develop some of the things that we've developed in this area is that thankfully, we are doing better than we ever have as a field in taking care of head and neck cancer patients, meaning we cure a lot more patients today than we did 15 or 20 years ago. Part of that has been because of sort of a change in the demographics of the disease. Part of that is because we're better at diagnosing it early and there's better treatment options. But one of the things, if you take care of head and neck cancer patients, particularly those who've had radiation, is that even the ones that you're successful in, and although this is better today than it was when I started in the field, almost 20 years ago, we still, leave those patients with a lot of side effects from their treatment. There's side effects and from the surgery that they might have. They're left with side effects from the chemotherapy, and they have side effects from the radiation as well. And the two things that we see from a radiation standpoint are, dry mouth or sticky saliva, and challenges with swallowing, and those really are highly related to one another. And despite the fact that we do a better job today because our machines are more precise and more sort of technically able to paint the radiation dose across the patient to the areas it needs to be and avoid the areas that we don't want it. The fact is that the head and neck is a really small area, and the salivary glands and the areas where the cancer sits are right next to each other in a lot of cases. And so even with the very best radiation planning and delivery, we still damage salivary production in patients. And so there's a clear need for better, for treatment options for these patients. When you look at sort of what's available for them, essentially what I tell my patients is to carry a water bottle with them, to drink a lot of water, to stay well hydrated, to see a dentist, multiple times a year. But there's nothing that really increases the amount of saliva they produce in a way that causes a normal function. And so that's sort of where this gap is in the field, and where Rob's group and our group and the group, there's a Danish group at the Riglitz Hospital that is also pursuing similar work. There's some companies that are pursuing similar work, but all sort of focused on how do we actually increase the amount of saliva that patients are producing. The question you asked about sort of disparities, I think there's a number of areas where we see this. One, we see disparities in sort of access to the highest quality radiation based on socioeconomic factors in this country, which is certainly unfortunate. We also see disparities in sort of the follow-up and the routine dental care that patients require. Again, I think this is in some part a consequence of our system in this country, and hopefully isn't something that Rob sees as much in the Netherlands as we do here, but certainly something that is a reality for patients treated across the United States. We don't view in this country, dental care is sort of separated from health care. And so, even if patients have health insurance, they may not have dental insurance. And so seeing a dentist, getting the preventative care can be really challenging. And, the saliva plays such a critical role in maintaining the health of your teeth, the health of your mouth and throat, in helping you to speak and to swallow and to sing, enabling people to go out to eat, to do all the things that sort of are part of our social functioning. And so, you may not think that, having less saliva is a big deal until you actually talk to somebody who's living with that, and it really can affect every part of their life.
I completely agree. And in the Netherlands, it's a bit different indeed. We have in Groningen, for instance, before you are radiated, you are going to the dentist already to make sure that everything that's not okay and can be damaged by lack of saliva is already taken care of before that. And that's indeed because of the system. So the dental care is separate, but if it's the result of another disease, then you come back to the normal healthcare system. So that's a tiny difference maybe, but that may make a big and in our case, we are focusing more on the prevention, right? So we try actually before the xerostomia is occurring already to prevent it by giving back stem cells before the real damage is already done, and you potentially already have lost your teeth. But that also means that a lot of patients, for the way we do the therapy, actually are not viable to do it because you need to take a biopsy of the stem cells before the radiation. And what Professor Kimple is doing is actually trying to cure the damage after it, right? So it's what we do is not exactly the same, and but we do benefit from each other's knowledge, I guess, and that's really helpful, I think. So can you already say a little bit about if you're allowed to how your patient respond to being asked for the study, but not only that, also do they already respond a bit on the therapy that you are giving?
Yeah. So just to give a little bit of sort of context, so our study, as Rob said, we're focused at least at this point on patients who are 2 years from sort of when they complete their radiation. So their cancer is there's a pretty good chance that their cancer is controlled or cured. They've been living with this dry mouth for a fair bit of time. So when we approach them about a potential treatment, and by this point in time, they've tried everything. They've tried hard candy. They've tried, sort of salivary substitutes, which are a little bit better than water, but not a whole lot better than water. They carry a water bottle with them. They've adapted their diet to the types of foods that they can eat. So they've sort of done everything. So when we say we have a study, they are thrilled to participate. And when I say that, participating in the study requires us to do a bone marrow biopsy, which means taking a big needle and sticking it into your hip bone, most of them are still happy to participate. We're working towards a day when we don't have to do that bone marrow biopsy on the patients, and that would certainly, I think, increase the enthusiasm that patients might have. But because patients are dealing with this and have been dealing with it for a long time and sort of haven't seen good alternatives, that certainly has not been a challenge for us. We've treated now, we ran a pilot study where we treated 6 patients. We're running a phase 1 study. We've treated 9 patients. Our 9th patient will come back in about a week for their 1-month follow-up, looking at safety. And then we have another 12 patients in that study that we're planning to enroll over the next year. The really good news is that in this approach where we take what are called mesenchymal stromal cells, sort of these cells that exist in a lot of different areas in the body. And we grow them up and culture them in a way that we can cryopreserve them or put them in a freezer for a period of time, because our patients come from hours away sometimes for this treatment. And so, just logistically, we need to be able to sort of pause the therapy or the preparation of things for them. And then we thaw them out, we sort of recover them overnight, and then we inject them into the submandibular glands. And the submandibular glands are 2 of the salivary glands, and they're really important because they provide sort of the basal throughout the day saliva. The parotid glands are a little bit larger. They respond to the smell of a really good apple pie baking, the smells that sort of make your mouth water. That's your parotid glands doing that. We've focused thus far just on the submandibular glands, although I hope that we can expand beyond that. So we inject the cells, one of our surgeons injects the cells into those salivary glands, and then we see the patients back. And I wish I could say that every patient benefits, but that's just not the case. But a significant number of our patients have have thus far had a real benefit. So I've had, ironically, or oddly, several patients come in really proud that they can spit again. Seems like an odd thing to be proud of, but when you can't do it, it's something that is sort of changing. And one was a grandpa, and he said, I was able to show my grandson how to spit, which I'm sure mom and dad were not thrilled about, but it's like that's a meaningful change. Another patient who said, boy, my wife and I are going out to eat with friends more often because I just feel more comfortable doing it because it's not back to normal. It's not back to what it was before radiation, but it's better than it was. And I can go to a restaurant and not have to, worry about what I'm ordering because I'm not going to be able to swallow the food because I'm so dry. I had another patient who feels like he's back almost entirely to what he was before treatment. And he's just absolutely thrilled every time I see him. And he's over a year out now with this sort of long-term benefit. And so it's incredibly exciting to see these patients back and, to see certainly the ones who are having a benefit and to see that lasting. So, it's a project that we're incredibly excited about and think is working, pretty well. There's questions that, we are really interested in, like, well, if a patient gets a small benefit, would a second injection provide more benefit? Would some combination of the approach we're taking and the approach that Rob is taking, where he, takes a biopsy of the salivary gland before they ever get radiation, would some combination of these approaches be even better than either of our approach alone? The reality is that, sort of moving something like that forward is complicated. It's easy to say we should put these things together, but it's a lot more complicated to actually do that. But I think there's a lot of opportunity to continue to push forward and find better treatments for these patients, which is really what's driving us.
Yeah, I completely agree. And what is important, I think, to potentially see what is causing the fact that it's working with some patients and others not, right? Because then you can point a bit more how to optimize this treatment, right? And the disadvantage, of course, is that if you have radiation, it's difficult to get a biopsy with the stem cells from the patient themselves back, and the salivary gland stem cell. So would it be an option? Would you think it would be an option to use, for instance, iPS cells, that you grow novel stem cells from a different tissue and then transform them to salivary gland stem cells, and then potentially in combination with mesenchymal cells, which are still necessary again, because I think they reduce the damage that's already there and maybe optimize space for stem cells, right? For adults.
Yeah, I mean, I think there absolutely is an opportunity for that. And, our approach right now is to use autologous cells, which means we're taking, a patient's cells and giving them back to that patient. There's, important benefits to that from a safety standpoint, you don't develop antibodies or an immune response to your own cells, but from a product standpoint, from a production standpoint, it's a whole lot easier if you could take, a single donor and give those cells to 100 patients. The challenge is that, some of those patients may develop antibodies and an immune reaction to those cells, so it may not have the same benefit that the sort of that initial or the autologous giving someone's cells back to them do. But I think there's tremendous opportunity for innovation and combination approaches to this problem.
So I wanted to talk about the patients, like when it comes to the communication or trying to gain that trust, especially when it comes to the treatment you're using. How was that, especially to probably like the older population that's in that cohort of treatment?
Yeah, so I think one of the big advantages, as a clinician, as a physician scientist that I have is a lot of the patients that I'm talking to about this study are patients that I've known for 2 or 3 or 5 years. And so I have that relationship already developed, or they're patients who are referred by my colleagues who have that relationship developed. And so, there's, I think we have to be careful as well that we're not overly biased in our, presentation of the risks of a study, because, gosh, I really want this to succeed. But I don't want to, tell patients things that aren't true or things that might bias them, one way or another. And so, we approach that by, I present a patient with a study, but then we have a clinical research coordinator who actually goes through the consent form and all the side effects and risks. And, she is not invested in the success of the study in the way that I am. And so, we try to present a fair and balanced, approach to the patients. But I think there's, huge benefits to, being a physician scientist and knowing these patients. And frankly, if I weren't, if I weren't a radiation oncologist, if I wasn't seeing these patients back, seeing the lack of good treatments for them, I'm not sure that we would have sort of been as enthusiastic about pursuing this work as we are now. And so it's can be hard to recognize as a scientist what why you're doing the work you are. You can sort of sometimes get lost in the details. And so I think having discussions with clinicians, working in a place where the doctors and the scientists get together once in a while to talk about, well, what are the problems that we're facing and what solutions might we have that we can, bring to bear on that, is really, a great opportunity to, try to find things that matter to our patients.
Yes, and that is very important that you are working in an environment where this collaboration is possible, right? So
yeah.
In our institute, we work together with oromaxillofacial surgeons that actually take the biopsies of the patient and operate the tumor, for instance, the first instance, radiotherapy, the biologist, but also, very importantly, the lab where you have to grow the cells, right? That has to be certified to a high level of safety. And that's not something that's easily established in every hospital, right? So I think this collaboration, we cannot underestimate this collaboration because it's really important to get these things done.
Yeah.
Yeah, and I do recognize what you say with the patients themselves. So in our case, we ask them to participate in something that they don't know yet. So they don't know yet what it means to
it's a lot harder.
Yes, and I'm not a doctor, so I don't see them. But the doctors, both the doctors, the oral maxillofacial surgeon and the radiation oncologist, they are easily in convincing these patients because when they once see the idea what they might have, then they are still very willing to participate.
We've talked a lot about how do we, because we're focused on patients right now who are 2 years out from their treatment, so they have xerostomia, they have dry mouth, but how do we move this treatment earlier where it could be more effective, and how do we convince patients who don't have dry mouth to take a step, and they may not get dry. We have a pretty good sense of who will and who won't, but we're not perfect at predicting that. And so how do we ethically convince a patient to participate in a study that might or might not benefit them down the road for something that they might get down the road is a challenge. And I think it can be done. But I think you need to be, thoughtful and careful as you go through that process. And so we're trying to approach that in as we're planning for the future.
And therefore, the safety study that you do is really hugely important because there's no risk. Because I don't know what you see, we hardly see any we call it side effects from the treatment itself. So once we establish that, I think if people may also be more open. Well, maybe what I'm thinking is how do you yeah, how did you get to this point, right? And were there any difficulties that you had to encounter during your career to end up in a cell therapy, which is maybe not logical for a former pharmacy study student?
Yeah. So I will, freely admit that the reason we ended up here is because, a cell therapy expert moved down the hall from us. So Jacques Gallipeau, who has been the head of the International Society, or the president of the International Society for Cell and Gene Therapy, relocated his lab to our university about 5 years ago, and he's on the same floor I am. And so, this literally began because we were talking in the hallway one day, and thought, boy, there's a real opportunity for us to work together in this area. I think it's fair to say that, had he not moved there, maybe even if he had moved to a different floor, we're both on the third floor. If he had moved to the fifth floor, we might have, said hi in the elevator once in a while, but we wouldn't have had a, 15-minute conversation standing, in the break room, to talk about and sort of to jumpstart this project. And then, I've been really fortunate to have a really great graduate student who herself was a cancer survivor and had radiation as a teenager, and so sort of understands what dry mouth is caused by radiation. And so she's taken on this project from a sort of a preclinical, a mouse model standpoint, and driven it forward. And I also think it's fair to say that, had she not sort of joined the lab at that time, we might not have, put the resources into this project that it took to sort of move things along. And so I think it's really been, a confluence of, happy coincidences that have led us here. I wish that I could say that there was some grand plan for decades, but it really was, we were in the right environment at the right time, with the right people, and we're able to recognize that there was a problem that, if we put the right team together, that we might be able to help solve. And I wouldn't say that we've solved it yet, but I think we're making progress towards that. And that's probably a really good lesson for scientists out there, for graduate students, people thinking about graduate school, is you've got to talk to people, not just in your field, but people outside of your field, and make those connections and collaborations, and think about how you can work together, how you can build teams to come together to solve problems. Because as Rob said, this is not just our lab doing this. It's a surgeon, and someone does the bone marrow biopsies, and we have a whole a specialized lab that grows the cells, that's highly regulated. Our clinical research staff, our the graduate students working on the project. It's just a whole team of individuals moving this forward.
Yeah, I definitely agree, because I'm actually collaborating with Albany Medical Center with head and neck cancer and Sjogren's syndrome patients. We do human collections, so I definitely agree that having the clinical perspective and also a scientist perspective and that collaboration definitely go hand in hand and help for better quality of life for future in the future for patients. What are some goals you have for the future of like hyposalivation treatment and current projects?
Yeah, I mean, I would love to be able to. I hope that our study ends up being successful. I would love to be able to offer this to patients, across the country, around the world. I've had patients who've reached out to me from, California and Florida and, Massachusetts, from Europe, and other places. So it's clear that there's, an unmet need out there in the field. I think, my hope for the future is that, between, the different groups that are pursuing treatments for these patients, is that we come up with, real options for head and neck cancer patients who suffer from dry mouth. And The other thing that I would say is that dry mouth is not just something that head and neck cancer patients deal with and suffer from, but patients with Sjogren's disease, autoimmune disorder, often develop really significant dry mouth. And so we actually have a colleague, Sarah McCoy, who's a rheumatologist, who is investigating sort of a very, very similar approach in Sjogren's patients and in graft versus host disease for patients who've had a bone marrow transplant. And we think, at least thus far, the data, the animal data looks promising that we may be able to be effective in those diseases. And so she's moving forward to just opened a phase 1 trial to look at the safety in sort of those different patient populations. So I hope that we can develop approaches that are going to benefit patients who have dry mouth from a number of different diseases. And then, I think the other aspect of this is that we can continue to train scientists, investigators to recognize that talking with their clinician colleagues, working as a team and thinking about what problems our patients are facing today, that maybe we can come up with a solution for down the road, I think is a really important long-term goal as well.
All right, thank you. So I appreciate the interviewee and the moderators for having this great discussion. I'm sure we can all learn something from the things you've talked about. As I mentioned, we will be uploading this discussion on YouTube, which will be for public access. So keep an eye out for that, and keep an eye out for our next sessions, which should be coming up in the near future. Thank you and have a good rest of your day.
Thanks, everybody. It was a lot of fun chatting.
Thank you. Bye-bye.
Thank you. Have a great one.